with that, let me introduce our speaker. It's a great pleasure to introduce someone. It's an oft-used word when we introduce speaker, but never truer than introducing Dr. Haulon. So as you'll see from his accent, he ain't from these here parts, you know, here in Texas, kind of like me. He's got a European accent, but his is a French accent as opposed to a British accent. He started general vascular surgery residency at Lille University Hospital, followed by a vascular surgery fellowship in 2000. In 2002, he defended a PhD thesis in biomaterial research, and then left France to do an endovascular fellowship at the Cleveland Clinic under the auspices of a Dr. Roy Greenberg. And Roy really was one of the pioneers of developing stent grafts, and his legacy, he died at a very young age, unfortunately, but his legacy because of people like Stephan that he trained is pretty remarkable. In 2003, Stephan returned to Lille as a staff vascular surgeon at the University Hospital. 2006, appointed professor of vascular surgery. In 2009, was invited to chair the vascular surgery department in Lille. In 2017, moved to head up at Big Aortic Center in France at the Hôpital Marie Lannelonga University Paris-Sud. How's that? Pretty good, huh? Not bad. So his main interest basically is in aortic surgery. He gave a lecture for us last night on how to minimize, using new techniques, how to minimize radiation exposure, which is important to all of us. I really don't want to go through all of these because I really want to hear from him. But suffice to say that he's truly one of the world leaders in developing some of the techniques and questioning some of the dogmas, particularly in a place like this. How do you treat aneurysms of the aortic arch? When I came down here, I remember Dr. DeBakey summoning me, and he said, Helen, there's chip shot descending thoracic aneurysm. And he said, can you put a stent graft in that? I wasn't sure what the right answer was supposed to be at that point in time. And I said, yes, sir. And he said, you know, we developed that operation here. And I said, yes, sir, I do realize that. And he said, but you know, it's a big operation. And if there's a more minimally invasive way of treating it, I want you to go ahead and do it. And I think that was the measure of the man. Even though big aortic surgery is what defined this place, people like DeBakey were always looking for the next way of treating it. And I think what you're going to hear today is a guy who's really challenging some of these dogmas and taking us to let us see a little bit about what hopefully we're going to be doing in the next couple of years. So Stephan, thank you. The long trip from Paris. He flew in yesterday, he's flying out this afternoon, so we appreciate the effort, and we're looking forward to hear from you. Thank you.
Thank you very much, Alan, for the invitation. It's a true privilege and an honor to be here at the Methodist, which is, for me, the mecca of aortic surgery. Obviously, I'm going to focus on my endovascular approach to those complex arch and thoracoabdominal dissection cases. And I work in an aortic center. An aortic center is a bit what you guys have here, is we're working cardiac surgeons, thoracic surgeons, vascular surgeons together. And for every patient, we discuss the best approach, which is it open, endo, or both, a hybrid approach. So we are open to everything. And obviously, I think that the take-home message is be able to perform all those procedures and decide what's best for your patients. I'm biased, and those are my disclosures. As Alan said, I have a PhD in biomaterials, and I've been working with the R&D of imaging and endograft companies for a very long time, because there was a very long road from the initial endograft that did fall apart quite quickly to the latest generation that we're using routinely today. Now, why am I focusing on dissection today? Because this is really one of the latest challenge, or one of the last challenge in the endovascular aortic world. Why is that? Is because when you look at a CT scan of one of those chronic dissections and you figure out you're gonna fix it with an endovascular approach, well, where is the proximal and where is the distal landing zones? Where are they? You're going to work in a narrow true lumen. You can see how this true lumen is compressed by the false lumen. You will have target vessel origin located in the true lumen for some of those, and in the false lumen on the other. So how do you reach those that are in the false lumen? And you have some of those target vessels that can be also dissected. And we'll see how we can fix all those different configurations. Now, I'm not here to tell you that acute type A dissection should be treated endo. This is not the take-home message. Although a couple of years ago, we looked at, I think, just below 100 cases of acute type A and looked at the anatomy thoroughly and figured out that maybe 1/3 of those patients could be treated with an endograft within the true lumen of the ascending aorta to cover a proximal entry tear that was not near the sinotubular junction or too near the innominate trunk origin. And obviously, those are a real challenge because on one side you have the valve and the coronary arteries, on the other side the supra-aortic trunk. Again, I think the first-line therapy, and there's no discussion here, should be open surgery because there are things we cannot really fix nowadays with an endovascular approach. I cannot do an endobental. And so the first step should be focusing on replacing the ascending endoroot and maybe in some of those patients with the dissection evolving towards the distal arch and the descending, this first open surgery can involve an elephant trunk frozen or a regular elephant trunk, which is a first step to a later endovascular approach. So that's why the discussion between the endovascular therapist and the CT surgeon is very important to always have a plan for the next step and discuss those cases together. So if the elephant trunk is positioned in the true lumen, which is the only challenge of this open surgery, or one of the challenges of this surgery, because then you can see here the true lumen, which is collapsed at the distal end of the arch. So if you position the elephant trunk in the true lumen, then relining the elephant trunk with an endograft is actually a piece of cake. It's very simple, straightforward endovascular procedure. But in some cases, and you can see here, the elephant trunk has been positioned in the false lumen, and they actually really looks like an elephant trunk. Then relining this elephant trunk with an endograft suddenly becomes quite a challenge and almost a nightmare. Fortunately for that patient, there was a small communication tear between the false lumen and the true lumen. So coming from the right arm, I managed to get in the elephant trunk, managed to find this communication tear, thanks to fusion imaging, and then with a wire that came from the right arm, I snared it from below and managed to get an endograft up and finally reline this elephant trunk. Just to tell you that if there had been a discussion between the CT surgeon and the endovascular surgeon prior to this first step procedure, the second step would have been much better and would not have exposed the patient to such a complex secondary endovascular procedure. Now, when I moved from my first center in Lille to Paris, I was surprised to see that the CT surgeons on my new center were performing a couple of wrapping procedure of the ascending for IQ type A. I always thought that this was not a good idea and that it was never working. And I actually had to look a couple of those cases. You see an acute type A dissection. Those are patients that have been turned down for open surgery because they're octogenarians or they have a medical condition that are prohibitive for a classic open pump surgery. And you can see here the wrapping of the ascending. And you can see when I saw that, it really looks like a perfect landing zone for an endograph. And this could be a first stage to a later endovascular procedure. And this video, if you can see it, you see the dissection of the dissected ascending aorta, making sure that we completely release the posterior wall of the ascending aorta from the pulmonary artery trunk and right pulmonary artery. And then making sure that you can get your Teflon plaque all around the ascending. And I think this is the most important trick, is to use a Teflon plaque and not a graft. And because you'll have some kind of snug fitting of the ascending. You see a phreoprolin suture of the Teflon plaque. And this is how you get this nice repair. And I've looked at 40 of those cases with a mean follow-up of 5 years. And the operative mortality was 9% in this high-risk group. And at a 5-year follow-up, the number of aneurysm-related secondary procedures is actually quite low. So maybe something to consider in high-risk patients. And how do you do this wrapping to generate a nice landing zone for a future endovascular approach? Well, the math is quite simple, and to get a diameter of 38 millimeter, you need to get a 120 millimeter large a Teflon plaque. And again, this is how it looks like. So we've started, because I actually moved away from the hybrids approach in the arch a couple of years ago, but with this technique, I went back and did a couple of those cases where you see the ascending was too large to be a proximal landing zone for an endograft, and so we had a wrapping. And the way we do the extraanatomic bypass is from the non-coronary sinus, so it provides a huge landing zone in the ascending to get the graft almost all the way to the sinotubular adjunction. So we did a couple of those, and I became lazy, so we did only the wrapping of the ascending and then an arch branch repair, so no extraanatomic bypass except for this transposition of the left subclavian artery. Having said that, the gold standard for acute IPA dissection repair is a tube in the ascending, and if the tube could be long enough to be in a perfect proximal landing zone for a future endovascular repair, and then that's perfect for us. And so in patients that are a high risk for redo open surgery, patients that have chronic dissecting aneurysms of the arch, we reline the proximal tube with a branch endograft to completely exclude the false lumen at the level of the arch. And just to show you how what type of endograft we use, we moved away from fenestrated devices, because the problem with the fenestration, they need to be positioned and perfectly in front of the origin of the supraortic trunk, and which is actually very complex because there are so many kinks before arriving at the level of the ascending that you do not control perfectly your delivery system, and you cannot rotate the endograft in the arch. We moved away from this first fenestrated option to a graft that was designed by Tim Shooter at UCSF. It was a single branch endograft that you would insert from the right common carotid. And now this is the device we're using. It's an inner branch endograft. Inner branch meaning that the branches are positioned inside the lumen of the endograft, and you access those branches from the top, the greater curvature of the graft, and you see you have this large opening from the top that gets you to the inner branch, and you see that there are a couple of gold markers that are helping us to understand how to perform those procedures. Now, this is an interesting view. You can see that the graft has a proximal sealing part, the first two stand, distal sealing, and then there's a tapering of the endograft at the level of the inner branches. Why is that? So that you always have perfusion of the supraortic trunk throughout the procedure. So like a TAAA procedure, on the rapid pacing, we open the endograft, and then you have flow going into the endograft through the inner branches and then into the supraortic trunk. So at no point you stop brain perfusion when doing those cases. And obviously the graft was designed to perfectly match the arch anatomy, which is quite a challenging place for an endograft. And you can see here the opening of the inner branch for the innominate and the one for the left common carotid here. Now, 2, 3, or maybe 4 years ago, I started becoming lazy and didn't want to do the transposition or a bypass to the left subclavian artery anymore. So I decided to add a third branch to those devices. Remember, the two first inner branches are antegrade. They go to the innominate and left common. And in order to avoid a crowded lumen at the level of the arch, the third branch is a retrograde branch going into the descending. And you can see that there's a preluded catheter here. So you have direct access from the groin to the branch, and then you just reline this inner branch with the left subclavian artery with a flexible covered stent. So this is how we perform those procedures. Again, quite similar to a TAAA approach with a wire into the left ventricle. The delivery system goes all the way through the valve into the left ventricle. On the rapid pacing, we release the endograft. And then from a right carotid approach, we access the endobranch and put a specific bridging stent. While inserting the delivery system of the innominate bridging stent, we clamp the carotid to protect the brain. Same thing is performed on the left side, but usually we use either a Viaban or Fluency self-expandable covered stent. And then, as I told you, from the groin, we have a direct access to the branch, catheterize the left subclavian, and use a flexible bridging stent here to perfuse the left subclavian artery. This is the free branch technology has been widely used in those chronic dissection cases following open repair of acute type A dissection. And those are a couple of examples. This is the typical case where following the tubular repair, you see a large communication tier between the true and the false lumen. And what you need to do with your endograft is to redirect the flow towards the true lumen to promote remodeling. And you can see here that the flow is now all the way to the true lumen, and with perfusion of the supraortic trunk and a transposition of the left common carotid here. And this is one of the first patients I treated with this approach. And you see remodeling at 2 years, but we're at 5 years now, and the remodeling is almost complete at the level of the arch. And I had planned to perform a thoracoabdominal repair during follow-up, but actually by covering this proximal entry tier, the false lumen at the mid-descending never evolved, and so she's stable, and I didn't have to do this second stage. A couple of other examples, you see the tube in the ascending, the large dissecting arch and descending thoracic aneurysm, and you can see a couple of those free branch devices. Now, those are the various steps of the procedure. You see that the wire is in the left ventricle. There's a rapid pacing probe that has been positioned in the right ventricle. You see under fusion guidance, we know exactly what the position of each, origin of each target vessel is. And once we, oops, there we are. And once we have positioned the graft correctly, under rapid pacing, we're gonna release the endograft. And this is what you're gonna see right away. Hopefully, there you are, first stent, second stent. And you see all the gold markers, I don't know if you can see them correctly, but are helping me to position the inner branches proximal to the origin of their target vessel. As soon as the graft has been delivered, we release the various trigger wires, and then we get the wire and the tip of the delivery system out of the left ventricle. So there's nothing more through the valve at this stage of the procedure than you have the time that you need to access those branches. Now, this is later on during the procedure. We've already positioned the branches into the innominate and left common carotid. Now, from the groin, I'm accessing the left subclavian artery, doing a selective angio to check the position of the origin of the vertebral artery. And you see the bridging stent has been positioned, obviously not covering, trying not to cover the left vertebral. And this is the completion angio, inner branches to the innominate and left common, and retrograde branch to the left subclavian artery. Now, we've looked at, as I think, 70 or 75 ascending cases post-type A open repair. And in our institution, we found that over 70 of those patients could be a candidate for a relining with a branch endograft. Those that would not be candidate are those with a very short ascending graft or an ascending graft with a major kink. So this has been the major reason for turning down patients for this approach, is those 90-degree kink. You can manage those kink if you can put the gap between the first two seating stents at the level of the kink, but then you need enough room on one side not to cover the coronary ostium, and on the other side not to cover the innominate. And then you also need the branch not to be positioned at the level of that kink, otherwise you generate some kind of pseudocoarctation. So you need to spend some time on the 3D workstation to check that you can have an endovascular approach to those cases. This is just another example of one of those patients. You see this kink I was quoting, putting the gap between the first two seating stents at the level of the kink. You can accommodate most of those patients, but not all. Now, there's an issue in some of those patients, is some of those patients had a repair with a bent-hole procedure. So there's a mechanical valve in some of those patients, mechanical aortic valve. And I showed you that you need to position the tip of the delivery system through the valve into the left ventricle. So how do you deal with that? So we had to change the delivery system. We cannot get this short tip through the valve, so we changed it to a bullet nose delivery system. And you can see here a sheath has been advanced all the way to the valve, and then the system is loaded into that sheath, and we can get the bullet nose next to the valve. And so you can see I cannot be right at the level of the coronary artery, so I need an ascending graft that is long enough, then doing the same technique, a rapid pacing, releasing the endograft, you will see that we end up being kind of 10 to 15 millimeters above the coronary. So if you have a tube that is long enough, Let me show you the completion angio. You see, we're not that far from the coronary arteries, and we managed, this was a young Marfan patient that had a 9-centimeter arch aneurysm after 2 stenotomies, spent, I think, 6 months in the ICU following the second one, so he was a no-go for a new stenotomy, and we managed to fix him endo. Now, we specifically looked at our results. This is a global registry on relining ascending graft in patient that had a prior type A ascending repair using those branch endograft. And we collected over 70 patients. And in this niche of patient, we had excellent outcomes, much better than the overall results we've reported previously with this technology in native aortas in aneurysm, atherosclerotic aneurysms. So the early experience with those devices in native aortas as a proximal landing zone with atherosclerotic aneurysm, we had a 10 to 15% mortality and stroke rate, whereas here you can see in those patients with the chronic dissection and prior open repair, we had a 4% combined mortality and stroke rate. And you have to compare that to a reduced stenotomy, deep hypothermia, frozen elephant trunk repair, cerebral protection. So I think that this niche of patient clearly benefits from this technology. So you can see that the technical success was quite high, but there's a cost to this nice result. There's the number of secondary procedure. 1/3 of the patient had to undergo secondary procedure, mostly to fix persistent false lumen perfusion, either from the dissected supraortic trunk. You can see here the nominate is dissected, the left common carotid is dissected. So how do you deal with that? You either do some supraortic trunk debranching or bypass prior to the surgery. So you can either get a right carotid to a right axillary bypass and then occlude the origin of the subclavian and get your branch all the way to the right common carotid. For the left common carotid, it's quite easy. We do a tube and then we get the branch all the way to the tube. Or other options is to position the endograft branch inside the true lumen here in the nominate and then come back later from an arm approach and close the false lumen with a couple of miles of course you need to use, and you need to use cores and not implanter plugs because we've had some issues with implanter plugs that you still have a patent false lumen through those plugs. Now, I talked about the supraortic trunk that can continue to feed the false lumen if they're dissected. One of the main issue is actually the false lumen that is perfused backward from dissection tiers that are located below the endograph, mostly at the level of the visceral artery. So you see flow is redirected towards the true lumen, then comes back in the false lumen, and the outflow is through intercostal. So this is how you get persistent perfusion of the false lumen, and that's why in those patients we've treated them by positioning what we call a candy plug, which is basically a very large occluder that we position in the false lumen at the level of the endograft that is positioned in the true lumen. And you can see that just after the procedure, you can see the collapsed true lumen in the true lumen because of the persistent flow and pressure in the false lumen. And a couple of months later, it's the opposite. You have an open true lumen and the false lumen that has been decompressed that is shrinking. This is the new generation of candy plug. Doesn't look like candy anymore. It's a big occlusion, big endograft that is positioned in the false lumen. And you can see that at the end of the procedure, after having positioned the graft in the true lumen, through a communication tier, we access from the true lumen into the false lumen. And then you see the graft in the true lumen. In the false lumen at the level, distal part of the endograft, we position this occlusion device. And you can see the completion angio in the true lumen. You can see flow coming back and stopping in the false lumen. You see backflow in the false lumen, but stops at the level of the occluder. So this is how you completely depressurize the false lumen, and this is how you get a complete exclusion of the false lumen. You can see the endograft in the true lumen. You can see the candy plug or occlusion device in the false lumen, flow into the true lumen, flow back in the false lumen, but no flow coming back up. So complete exclusion of the false lumen. And this was a bit the missing part for all those chronic dissections that we were treating before. This is an example of a patient with a dilated false lumen at the level of the arch, but the rest of the dissected thoracic aorta was not dilated. So we got the graft to the mid-descending and positioned the candid plug into the false lumen to completely exclude this arch false lumen. And this is a recent patient, I can't remember where. So this is the end of the arch branch procedure. You'll see the completion angio. So we have completely excluded the proximal entry tier. And then during the same procedure, at the end, we look for a communication tier between the true and the false. We often find this communication tier at the level of one of the common iliac. And so I get away from the true lumen and try and access the false lumen. Let me try and move forward. You see here, I keep a wire into the true lumen and I move the large sheath back into the external. And I'm looking from my way into the false lumen, which now I have achieved. I am in the false lumen. And I double check that I'm in the false lumen by pushing the wire into the proximal descending. And you can see that the wire is now not anymore in the true lumen where you have the endograft, but in the large dilated false lumen. And over this wire, I advance the occlusion device, the candid plug, and you see opening it right at the distal end at the same level of the graft inside the true lumen. So this candid plug or occlusion device in the false lumen is a very good idea, except if you have a very large false lumen in the descending thoracic aorta. If you have a dissected thoracoabdominal aorta, if you put a candid plug in the false lumen, it's just going to be in the middle of a large lumen, and so it doesn't make any sense. So for those patients with a very large descending thoracic or thoracoabdominal false lumen, there's no way that the candid plug can be a good option. So for those patients, we reline the branched proximal repair with a fenestrated repair. So the idea is to completely disconnect any communication between the true and the false lumen. So sometimes it means going all the way down to the common iliac. This is the patient I showed you previously with the mechanical valve that we had to reline also. What was interesting is 1 year after the initial procedure, the 9-centimeter arch aneurysm had completely disappeared, so I thought that was great, except that below the thoracoabdominal segment went from 45 to 60, so that's why we had to reline it. And sometimes the communication tier is inside the common iliac, so in those patients we need to add a branch to one of the internal. So this patient has 2 branches to the supra-aortic trunk, 4 fenestration here, and 1 branch at the level of the internal. And those full metal jackets, we have to stage the procedure to reduce the spinal cord ischemia, and I'll talk about that later on. And this was the topic of my talk yesterday evening. You cannot perform those procedures if you don't have access to a last generation hybrid room, because you need to have a fusion mask of the true, of the false lumen. You need to have markers of the origin of each target vessel, especially those that are arising inside the false lumen, and you need to have the marker of the communication tiers between the true and the false lumen, because in those patients you need to get the graft in the true lumen, you need to go through the fenestration, through the communication tier into the false lumen, then into the target vessel. So you need advanced imaging applications such as fusion guidance, and at the end of the procedure, doing an AP angio is not enough because you're going to miss a lot of the complications. So you need to do 3D imaging. So we perform cone beam CTs in all of those patients at the end of the procedure to make sure that all those bridging stents and branches are nicely positioned, that there's no endoleak, no kink, and if there's any issue, we can fix it right away. So I told you we have a stage approach to those patients, and this is a typical chronic dissection patient. When he was 50 years, which is me last year, he got an acute type A dissection, and so he went to our CT surgeon, performed an open repair. Then 4 years later, he had to undergo a reduced stenotomy because of a root issue. He had a Tyrone David repair, and because the arch also had evolved, so he had a Tyrone David plus arch repair and an elephant trunk. Now his descending continued to enlarge, so I had to reline the elephant trunk with an endograft. So this was stage number 3. You see the endograft here is positioned in the elephant trunk into the descending all the way to the celiac trunk. Then he continued to enlarge, and because he had a very complex dissection involving both common iliacs and going all the way to the external, decided to do the distal part open so that we could keep both internal iliac open because this is mandatory if you want to reduce the spinal cord ischemia risk. So we did step number 4 open. So now he has an open repair at the top with an elephant trunk, an endograft going all the way to the celiac trunk here, and he has open repair going from below the renals to the common iliacs here. You can see how the endograft inside the true lumen looks kind of collapsed. There's a kind of pseudocoactation because you have false lumen, perfusion, and pressure compressing the true lumen. Now, positioning an endograft in a dissected aorta is not, especially a fenestrated endograft, is not always an easy procedure, especially if some of the target vessel are perfused by the false lumen. So you see we designed here an endograft with 4 fenestration, 2 for the visceral arteries and 1 for the left renal, which were perfused by the true lumen, so an easy one to size. But this fenestration for the right renal was positioned at the communication tier between the true and the false lumen to access the right renal. And you can see that you have to look for those communication tiers that are positioned, that are perfusing, that are actually away from the true lumen to the false and then to the target vessel. Most of the patients will have a communication tier located at the level of the target vessel, most, but not all, and I'll show you why. And this is the procedure. The endograft is in position in the true lumen. We are through the fenestration into the false lumen and then all the way to the right renal. So we need to use a long bridging stent to completely exclude the false lumen here. And this is the full metal jacket CT during follow-up, and the patient was discharged with no spinal cord ischemia. Now remember I told you, look at the TEVAR, and the distal end of the TEVAR was collapsed in the true lumen, and you can see there's flow and pressure in the false lumen. So you see how it looks like. And this is the CT scan performed a couple of days after the FEVAR. And because we have completely disconnected true and false lumen by covering all communications here, the pressure instantly reduces in the false lumen and the endograft in the true lumen opens. So at the beginning of the experience, we were really concerned, having performed quite a significant number of open repair. The dissection flap is quite thick and it's difficult to cut. We thought that this would not be flexible at all, but it's actually the true lumen collapse is only a question of pressure in the false lumen. And once you exclude any pressure from the false lumen, then the true lumen reopens to its maximum diameter. So the way I size those endografts is I actually look at the maximum diameter of the true lumen, and this is going to be the diameter of my endograft at that level. So usually I say that the endograft, the true lumen goes from a French croissant shape to an American donut shape, and this is really when the treatment is a success, meaning that you have no more communication. So when you do the cone beam CT at the end of the procedure, if you see that evolution from a croissant to a donut, then you know you've done a good job. If the true lumen is still collapsed, then you know that the CT scan will find some kind of perfusion of the false lumen, and you will need a secondary procedure to exclude. Can be an embolization. And look, this, you would think that this true lumen is a contraindication to endo. This is the same patient at the level of the right renal artery. You see how it had opened, and you see the stent bridging the false lumen and perfusing the right kidney. Now, I told you that most of those patients have a communication tier at the level of the origin of a target vessel that is perfused by the false lumen. Well, it's not the case for everyone, and you can see in this chronic dissection, there's a very thick dissection flap here in front of the right renal, and there's really no communication at all. So for those patients, we either create a communication tier, we can use a laser probe, or we can use a 1-4 wire backward, or you look for a communication between true and false lumen above the origin of the target vessel, and this is what we have here. In the mid-descending, we have a communication between true and false lumen. So for this specific patient, we did a 2-stage approach. We first repaired the proximal descending with a branched endograft. Let's say this is a branch for the left subclavian artery and a scallop for the left common. And then we came back a couple of weeks later with the intermediate component that has a branch, and this branch is positioned just above the communication tier. And from an arm approach, you get through the branch, through the dissection tier, and then to the right renal artery. And then a distal free vessel fenestrated endograft for those 3 other target vessels that are perfused by the true lumen. A couple of images from the first procedure for this, the branch endograph, and this is the second procedure. You see I'm looking for that communication tier, and you see it has been located with my fusion mask, and I position the branch of this intermediate component just above the communication tier. And then from the arm approach, I go through the branch, through the communication tier into the false lumen, and with a long via band here, all the way to this right kidney. You see a nice perfusion of the kidney, and the other 3 vessels are perfused through fenestration. And you can see this true false lumen, that was patent prior to the procedure, is now completely occluded and is going to shrink during follow-up. Another example, you can see here that the 3 vessels, right renal and both vessels, are perfused by the false lumen. You can see a large entry tier in the mid-descending. So for that patient, we had 3 branches to get access to the false lumen and 1 fenestration for this left renal artery that is located in the true lumen. So you see it's really a customized approach to each patient's anatomy, and you have to have a plan to make sure that you can access those target vessels. You see the 3 branches and the fenestration here for the left renal artery. And you see again an occluded false lumen. And you see this is the fenestration to the left renal, and those are the 3 branches to the visceral and right kidney. Another issue that we have to tackle is those dissected target vessel. So if you position in this dissected SMA, if you're coming from the true lumen and you position a bridging stent into the true lumen, very good. But what's going to happen? You're going to perfuse your SMA, and then you will have backflow into the false lumen through this communication tier within the SMA. So for those patients, what we do is at the beginning of the procedure, we leave a wire into the false lumen of this target vessel, and then once we have completed the endo repair, we position either coils or an implanted plug in the false lumen, completely disconnect any backflow towards the false lumen of the aorta. So again, you need to have a plan, and so you need to spend time on the workstation to make sure that you're going to completely exclude. So this patient has a left kidney perfused by the false lumen, and you can see that the dissection goes all the way to the common iliac, and this is the internal iliac origin. So if you position a graft in the true lumen inside the common iliac, you'll have backflow to the false lumen, which is what you want to avoid. So in this patient, we had to position a branch iliac endograft to completely exclude backflow, and on the other side, we position implanted plug in the false lumen. This is an interesting one. This patient had a prior open repair of an ascending, and you can see during follow-up enlargement, quite significant. It's a woman of the thoracoabdominal dissection, and you can see it goes all the way down to the iliac on the right side. But what is quite difficult to tackle in this patient is there is dissection of the origin of the left common and of the left subclavian artery, and the left subclavian is dissected actually all the way to the axillary. So if you want to do a bypass in those patients to have a proximal landing zone going all the way to the left common, then it's quite complex because you're working on a dissected axillary or left subclavian, sorry. So usually what we do is we clamp a very diseased vessel, and then we try to cut the flap inside the lumen. You never know what's going to happen next, and sometimes you need to reline those with stents. But in this patient, what we did is we first came through the left arm and went and selectively accessed the false lumen, and we kept the catheter inside. Then from the true lumen from below, we advanced the endograft. You see the endograft number has been released, and from the bottom, from the groin, we go through the branch within the true lumen of the left subclavian artery. So you have a wire coming from below in the true lumen, and a catheter and wire coming from above in the false lumen. And so once the branch has been positioned, we co-embolize this false lumen and completely exclude all the dissection part of the origin of the supraortic trunk. So this patient was supposed to be a stage approach, but I had some issues to get the device, the arch device up through the left common iliac, and you can see actually. I checked at the end of the procedure, I had ruptured the left common iliac, so I had planned to stage it, but I had to fix the whole aorta from top to bottom in this patient. So we finished the case by positioning the fenestrated endograft and the iliac branch. So you can see the repair was performed as a one-shot, which is I try to avoid, but in that specific case, I had no choice. And you can see that the false lumen is nicely excluded in the iliac branch on the right side, and you can see in the arch, normal perfusion of the dissected supraortic trunk. And you can see that here is the branch in the left subclavian artery, the vertebral artery origin. So all the origin is completely excluded, and you still have the dissection to the axillary, but we don't care. We have a good flow and no back feeding of the false lumen. Let me come back a couple of seconds to this branch device to generate a proximal landing zone in those chronic type B dissection. It's a graft, and I've been working on and this graft is supposed to be an off-the-shelf endograft to be available for acute type B dissection. So you get a proximal scallop for the left common and a retrograde branch to the left subclavian artery. And you can see because you have a preloaded catheter, you have access directly to that branch from below, and then it's easier than an iliac branch device because the left subclavian artery usually origins 10-12 millimeter right at the top, so getting access is really not an issue. The issue can be maybe the bridging stent. We currently are using the Viaband, but we would need to have a specific dedicated bridging stent for that left subclavian artery. So we started the program with this device on chronic dissection cases, and we specifically look at the anatomy of the origin of the left subclavian. So this is the branch perfusing left subclavian, and this is the scallop for making sure that the nominate and left common carotid will not be covered. And you can see the result by getting a branch into the left subclavian. You completely exclude the proximal entry tier that is often located at the origin and then slightly protruding inside the left subclavian, and so you completely exclude those false lumen. And to have an off-the-shelf device, we looked at 196 cases, TVAR cases, that had a coverage of the left subclavian artery. And we took patients from our center and also patients from the stable study from Cook, it's an acute diabetic dissection study, and the clinical trial, the pivotal trial from the alpha thoracic graft. So we look at almost 200 patients, and we had a thorough analysis of the arch anatomy in those patients, and you see there's a lot of data was collected to see the position of each of the target vessel. And we came up also with the mean diameter of the left subclavian artery, the distance from the origin to the left vertebral, and then we came up with a design that could fit most of those patients. It's a helical branch so that you can nicely adapt to the specific anatomy of the left subclavian artery. And this device with this approximal 30 millimeter large scallop and this retrograde branch can actually be applicable to 80% of those cases where you need to cover the left subclavian artery. So in the middle of the night, when you have an acute IB dissection, where performing a bypass or transposition is not always something you want to do because there's a life-threatening condition for the patient, this easy branch endograph is probably an option, and it soon will be available, hopefully. I talked about the spinal cord ischemia risk because we're covering the aorta from top to bottom, and how do we reduce the spinal cord ischemia risk? Well, by staging those procedures. The best way to stage them, and it's quite easy in chronic dissection, is to have a two-step aortic coverage with first the thoracic endograft and then the fenestrated or branch endograft. There are other techniques like temporary aneurysm sac perfusion or stage segmental artery embolization. So this is one of the staging. You can see the arch hybrid repair with a first TVAR, and you can see that there's a distal type 1 endoleak, but we don't care because we know we're going to reline with the fenestrated endograft later on. And the other techniques are the perfusion branches. You can either keep one of the visceral branches open and then come back later and reline it to the target vessel, or you can have specific perfusion branches that are positioned at the back of the endograph. I don't like this approach because you're perfusing a dead end, and if you keep one of those target vessel not stented, you might actually lose it. It might occlude during this interval period. And also there's been a couple of quite dramatic coagulopathies that have been reported with this approach. So I'd rather do it the way I do it currently, is first a TVAR and then the FEVAR, and sometimes I do some misatch, which is an intercostal embolization. You can see here, this is a technique that has been described by the group from ETS in Germany, in Leipzig. And you can see that when you embolize those, you really have to embolize the trunk and only the trunk. This is one patient that had multiple open surgeries and then ended up with the top of the descending that was repaired open. Then they put an endograft, and he had an Aorta by iliac repair. Both his internal are occluded, and he comes to my clinic with his large thoracoabdominal aneurysm and two patent, very large intercostal. I'm quite concerned that I'm going to get him paraplegic if I just cover everything. You see, he's at very, very high risk of spinal cord ischemia. So what we did is we staged the embolization of those intercostals. So at the first stage, I occluded one of the intercostal, putting an implanted plug. He's under local anesthesia. I positioned the plug, but without releasing it completely. After 20 minutes, he's still moving his legs. I decided to release it. Then, so this is the first stage. Then this is the second stage. I'm now a couple of weeks later doing the same thing for the second intercostal. And then a couple of weeks later, we performed the surgery on the CSF drainage. We monitor very carefully our CSF drainage. And then we did this branch repair from the groin using a steerable sheath. And this is the completion angio and the cone beam CT at the end of the procedure. And you can see that with the cone beam CT, the two implanted plugs that have been positioned within the intercostal arteries. And by staging, multiple staging approach, we managed to discharge this patient with no spinal cord ischemia. So probably I need to run through quickly. Yeah, okay, sorry. So this is just to show you that we can tackle all challenging anatomies if the patient has no other option, no open option. And I'm not going to show you this video, or maybe just so you have a couple of nightmares. You see how we can handle a very tortuous anatomy using through and through a wire access from the right arm to the arch. You see, we can actually manage most of those angulation. And let's just go directly to the final result. And then this, we presented at the SVS in San Francisco a couple of years ago, our initial experience with the chronic dissections. So this was a total of 43 at that time. We've performed almost 150 of those now. And the results are have been quite consistent with a mortality, 30-day mortality rate of less than 5%, a spinal cord ischemia rate that is approximately the same, but quite a high number of secondary procedures, because there's been a learning curve on how to select the correct bridging stent, because those target vessels are larger, and sometimes you're too short into the false lumen, so there's been quite a significant number of secondary procedures. And all this is to show you that the patency of renal and visceral artery stents, there's been a lot of data published, and the best data available is the US consortium from ODIDA performed in the US. You see on over 600 thoracoabdominal repair. You can see here target artery patency, secondary patency rate of 99% at 2 years. This is the end of the talk. I just want to tell you that I'm not here to push the endovascular approach. This is a 37-year-old man that arrived with this huge chronic type A dissection, almost 80 millimeter. Obviously, we didn't wait for a custom-made device that requires 2 months to be manufactured. We did a thoracotomy and re-implanted his left subclavian artery, and he did well. This is another case where the patient arrived with chest pain, 11 centimeter type 2 thoracoabdominal aneurysm, contain rupture. We did the proximal part open. He was discharged, but because of the 6 centimeter thoracoabdominal aneurysm, he came back later, and we relined the proximal open repair with a branch repair, and the patient was discharged nicely. So in conclusion, those chronic dissections are either very simple or can be very complex to treat. So you really need 3D imaging to select the right patient, to have a plan and to design your custom-made approach. We do stage approach, hybrid repairs, meaning that you need to have the expertise in both open and endovascular procedures. So I'm not here to promote the endovascular approach. I'm here to promote performing those cases in high volume centers with a discussion on how best to tackle those complex cases. Thank you again so much for the invitation.
Well, that's a spectacular review of what's really the state of the aorta, actually in front of the state of the aorta at the moment, because most of us don't have access to this. So questions, I'm sure there's some questions. Can we get a microphone to Dr. Peden, please?
Stephan, that was really impressive. Can I ask, in these ones where the dissection goes up into the carotids, how are you dealing with that with this device? Because you kind of intimated that sometimes it is going all the way up and you're opening that, yeah?
So in our experience, when the dissection goes all the way to the carotid, most of the time dissection flaps ends up at the bifurcation of the carotid. So we do an open approach, and we do a bypass, a common carotid bypass all the way to the bifurcation. We clamp the internal, and we cut the intimal flap in the internal. And in this 8 millimeter bypass, we get the branch of our endograft. So it's the best way to do those, and so again, staging might mean first performing a couple of those supraortic trunk procedures, and then getting them to the hybrid room to do the endo repair.
Mahesh.
Thank you. That was spectacular. I was intrigued in the early part of your talk when you spoke about wrapping the aorta. Is that something that you're still doing? And if so, how do you select patients for that?
So that's why I now include those slides in my talk, because when I moved to Paris, and I was very intrigued to see that the cardiac surgeons were performing this type of surgery, although they're a high-volume center performing all type of repair. And so they have a specific program, and when they accept all those cases that have been contraindicated for open surgery from other centers. And in this only subgroup of patients with no major valve regurgitation, they perform this approach. Because I was really concerned about the long-term outcomes, the follow-up outcomes, I just had a fellow to review all the data, and I have to say I'm quite surprised to see that the outcomes are actually quite good, and there's not that many secondary procedures, and in hospital mortality is very low, although it is a high risk surgical group. Having said that, this is not our first-line therapy, and this is just a small subset of patients that have been contraindicated for a standard approach.
If I recall correctly, you said that the mortality in these patients was around 10%.
Exactly.
Well, the latest registry data were presented at the STS at the Society of Thoracic Surgeons meeting just a few weeks ago. And the mortality for type A dissection, type 1 dissection, excuse me.
We're in the DeBakey Center,
Yeah, is still stubbornly at around 20%. So,
and this is exactly what we have in our center. We have currently, I think it's 17 or 18% mortality with this standard repair. So it is a surprise, and again, we might think out of the box, and in the future there might be new approaches with this approach, and maybe relining the true lumen with an endograft, so you can have some kind of sandwich of the ascending with a complete exclusion and promoting aortic remodeling. I don't know what is the good option, but we probably need to figure out if there's not another way of fixing those acute type A. But I have to agree that I was very surprised that I was doing that when I moved to that center.
So you are not at the point where you are recommending this as an approach?
Not at all, not at all, not at all, and I hope I made it clear.
So let me, sorry. So let me ask you a question, and that is, you emphasized staged approach. I mean, sometimes you look at these things, and it's just overwhelming. I mean, the whole aorta is abnormal, it's dissected, there are focal areas basically of aneurysm degeneration. You look at it and go, where do I start? So I'm really interested in how do you choose what you're going to tackle first? Obviously, type A dissection, pretty easy. But in the chronic situation, how do you choose what you're going to tackle first? And then what's the cadence of the secondary interventions? And then ultimately, what's in the back of all our mind, do you lose patients between the first stage, unprotecting the rest of the aorta, and them rupturing before they come back to that?
That's a critical point. And So staging is really to reduce spinal cord ischemia. That's what we've learned with experience, and the Cleveland Clinic has published a nice paper showing incredible numbers how significantly you reduce the spinal cord ischemia. Now, when we treat chronic dissections, staging is very easy because you just put an endograft inside within the true lumen, and then come back and reline it with a fenestrated endograft. Now, the real issue is when you're treating type 2 thoracoabdominal, you don't always have a place to get some kind of distal seal. And what do? Do you put an endograft inside a large lumen that is just floating? I'm not sure it's a good idea. So we've used a couple of custom-made devices and try at the level of a kink or at the level of the diaphragm to get a distal seal with a 46 or a 50 millimeter distal sealing stance to promote some kind of occlusion of the proximal descending thoracic, and then come back and relining that first graft with an endograft going all the way to the arch. So, do we lose any patient? Not that many. Did we have ruptures? Yes. During this interval timing, we had a patient that after just the TEVAR had an MI, then underwent cardiac surgery, then went to rehab, and then his graft was waiting in the hospital. And I remember I was actually doing ground rounds at UMass. They called me and saying, well, the guy is back with a rupture. And we had the endograft in the hospital, so it was a contained rupture, but it was a rupture. So the next morning, we fixed him with the fenestrated endograft. But so ruptures can happen, and never make sure that those patients come back to the hospital.
So by and large, the cadence, the time between proximal stent graft and the fenestration, roughly, what are you looking for?
So roughly the way we do it, we position the TEVAR, and then we shoot a new CT scan after that procedure, and this is when we order the second component, and it requires approximately 8 weeks to get the second component. So this is rocket science. We get them back to the hospital when we have the grafts. Yeah, exactly.
All right. Well, we probably need to wind it up. Thank you very much. That was a fascinating glimpse in the future, and I appreciate the audience being here. Thank you. Thank you very much. Very good.
Thank you for the invitation. That's really nice.
Really good.